wanted to start with thanking APOS and AOS, but I want to thank the people sitting in the room for attending this. Thank you. So, art is long and life is short, and refraction is indeed an art. So, as this topic is about subjective refraction and the way I do it, so it could be subjective. That's a disclaimer. So, what is infinity for human eye? Infinity for you, all universe is galaxies and galaxies away, but infinity for human eye is just anything over 20 feet is infinity for human eye. And from infinity to the near point, at every point you need some sort of accommodation, so refraction is dynamic. So where to start? Obviously vision, but listen to the patient. He is telling you his intent, or especially the female patients, their intent to use or their dislike for the specs. So it's most often it happens is certain patients come together and say that their headache will go away with specs. Indeed, you are dealing with a refractive patient. And most of the times, the patient not knowing the optotypes is the one of the most important common cause of defective vision. They won't reveal it, but once you literate Snellen charts are used, they won't. They say that they couldn't see, and when you press, they will say that their formal education is not there. So, and present glasses of the patient are one of the most important point to start the refraction. So I will be dealing with under these subheadings. It's machine myopia, pseudo myopia, and night myopia. So what is machine myopia? The typical case scenario will be a young boy will come for a routine checkup, but the machine throws up a reading of -5, -6, -7 readings. If you just see bilateral visual acuity, it will be 6/6. So, and once you take repeated readings, the initial high readings of minus will go away. And the second most important point, important thing I want to discuss is pseudomyopia. So the typical patient will be like this. Again, students, after reading for some time, they're defective and the distant vision becomes defective. So, and certain patients, they come for headaches. So how do you recognize these patients? Again, the manifest refraction will be more than what they could read unaided with both eyes open, and cycloplegia will reveal this. But again, how do you correct them? So basically, they will be happy with certain minus power. Their defective vision won't go if you don't give a minus power. So curtail it to a minimum extent. Give a cycloplegic drop at the night time, and curtain the near work. Let them ask them to take breaks. And night myopia, I don't have any experience with it. Some people require a degree more of high, a bit more diopters at night. So hyperopia, again, the most of the times, though it's called long-sightedness, they present with defective vision for distance. So, and most common cause is brow-ache and frontal headaches. Automatically warrants cycloplegia. Again, will the patient accept? So though the teaching is to give the maximum plus, the patient may not accept it. Try, give a minimum plus, and gradually as the accommodation relaxes, then they will accept. So astigmatism, another most important cause of ophthalmic headaches. Present glass, they are treasure trove for astigmatism. You just don't tweak too much of axis or the cylinder from the present glass. And sum total and astigmatic axis in most patients will be 180 degrees to each other. So use this principle. So once you can fix one axis, the other axis will be 180 minus that, and most of the times the patient will accept that. And prescribing the cylinder for the first time in an older patient, more than 20 years old, don't give more than 0.75 cylinders. Just adjust the spherical equivalent, and keep the trial frame on and ask the patient to move about in the OPD, and that's called the trial run. And if you can't accept that then and there, then he may not accept afterwards also. So presbyopia, again, don't go by rule of thumbs. Ask the patient to what he does and what his near distance, what is near vision, what is the near working distance is. So, and confirm the actual accuracy of distant correction. And again, don't tweak too much with the present glasses. For the patient who comes with a routine checkup, don't give more than 0.5 to 1 diopters more than the present ad. And most of the times, the patients will be comfortable, illiterates, they will be comfortable without the bifocals. Actually, that's an hindrance for them. And in routine camps, what happens is they give plano by +3, which is a hindrance for them. And remember that bifocals are one of the main cause for falls in the elderly. So, I mean, progressive additional lens, these are, apart from aesthetics, they fill a very, they fill a void that is not treated by bifocals. That's the intermediate vision. So, but the pitfalls are costs and needs for the adjustment. For example, if the patient is already using bifocals or if he's having significant astigmatism, progressive additional lenses may require some time. And the, and the other thing is, routinely with classes, what we do is we turn our eyes to see things, but with the progressive additional lens, we should turn our head sideways or up and down to see things. And another tip I want to give is the add in the progressive additional lenses will be a little bit more than a routine bifocal, because the very moment you hit the near segment, you don't get the total power. So give a little bit more add in a progressive additional lens. So cycloplegia, when to do it's a must. Of course, anyone below 12 years, it's a must, you do. And patient consent is very important. For example, don't take it lightly. I have seen fights erupt in OPD because we have not mentioned that, and the patient has got incapacitated, he has to go somewhere else. So take patient consent, and when you don't get adequate cycloplegia, don't keep on increasing the dosage. Just increase the strength of the drug or skip the drug altogether and go for a more powerful drug. And they do have side effects. I have seen children getting delirious after cyclopentolate. And post-cycloplegic test, is it required at every point of the time? I mean, post-cycloplegic test is not required. Sometimes, as a benefit of doubt, you want to do cycloplegia, but you can do one thing. You can prescribe the glasses subjectively, do cycloplegic test, and there are no great surprises, just prescribe the glasses. And refraction in children, of course, you know that hyperopia may correct over a period of time, and mild myopia need not be corrected, but any refractive error beyond the age of 6 should be fully corrected, and constant use of glass is recommended, definitely in case of exophoria and even for near reading, because to accommodate to convergence, to encourage that, you ask the patient to use the glasses constantly. And this one point I have seen so many patients. Anisometric amblyopia occurs pretty commonly in hyperopes and asymmetric hyperopes, and they will be blind for life. So catching them early and treating them will be a great boon, more than cataract surgery. So 6/6 and N6 is not the holy grail, but the patient's comfort in day-to-day activities are holy grail. So it's an art of, it's mostly about first impressions. The subject to refraction, the moment you put a glass, you know that whether the patient is liking the glass or not. So it's all about first impressions, and don't be tough on yourself and the patient. And one trick is, if the patient is still nagging that he is not able to see clearly 6/6, just show him with both eyes open. Bilateral visual acuity somehow will be better than each individual eye. I don't know the reason, maybe simultaneous macular perception or something, but it'll save many headaches and chair time. Thank you.